Well, welcome. Tonight, a profession I'll never figure out. If I had to spend half my life studying, I think I would have picked pediatrician or something I can do of course I'm going to get comments that it's not 9 to 5, kids get sick all the time, but why don't we start with an introduction?
I'm Brittany Weber. I'm an obstetrician at Blackstone Valley OB-Gyn, which is part of Tri-County Medical Associates. I practice at their office in Northbridge and also Milford Regional Medical Center.
Now, the new facility, right?
Yes. It's very exciting. We have a brand new building there in Northbridge that's part of Milford Regional Medical Center. We have our practice, Blackstone Valley OB-Gyn. There's also Blackstone Valley Family Practice there, so there's a full primary care practice there. We also have Milford Regional Services that include laboratory services, imaging. We're very excited that probably this summer we're going to be offering ultrasound services in their new ultrasound suite. And there's also physical therapy and sports medicine available there.
Sounds like Uncle Phil and Uncle Ed and Frank have been very busy.
They have been very busy. It's a beautiful facility. We're really excited to be there. We're still settling in, but really liking it.
Now, I've got to ask, of all the professions, you know, I think of obstetrics as the biggest roller coaster, you know, of emotions. How did you pick OB-GYN? Or why?
Sometimes I ask myself that, but it's kind of interesting. I started medical school dead set on emergency medicine. I was not.
Oh, that's a pleasant ease.
I was not interested in anything else. That was where I was going. And I went to UMass Medical School. And part of the curriculum there is you have a long-term preceptorship program. And UMass is very into primary care, and they try to put people in with primary care doctors. Well, they had double booked me. They assigned me with someone, a family practice physician who already had a student. And I called up to get scheduled to go work with her, and she said, I already have a student. Click. So I sobbed.
Wow.
I sobbed for a little bit. Got on the phone with the person who ran the program, and she kind of hemmed and hawed, and she went, well, what would you think about going with an OB-GYN? And my first thoughts were like,
no.
I was really kind of horrified at the thought, but it was kind of
never sleeping, never having a schedule, not having a life. I mean, besides that.
But then there was the thought of not meeting my curriculum requirements, and it's like, okay, I'll do it. And a couple weeks later, I'm in the OB-GYN's office and getting to see the relationship she had with her patients through all age ranges, and then I got to see my first birth.
Oh.
And I got to see how truly spectacular it is to be part of that incredible moment in someone's life, and I was hooked.
Probably one of my most precious possessions. And it always sounds terrible that you film the birth. Yes, I didn't care about the business end of the transaction.
Yep.
But there's about a 10-second clip where my daughters, you know, are coming up, and it's the first time mom got to hug the baby. I watched it because I'm having a grandchild. My first boy, it's going to be news, because usually boys we poked with a sharp stick. We didn't want him in the house. So this will be the first time that a boy is welcome in the house. But I thought about it. I went back and watched the movie. Oh my God. You know, you still, you know, the chills of there's my life. You know, my darling bride and my daughters right there.
Yeah. It's funny, thousands of babies later, and I still tear up. It's just such a special moment, and to get to be part of that is really wonderful.
So how much of the practice time is delivering babies? I mean, is this like TV where you see, you know, the police are always action, right? There's always action, there's always going, but in real life?
Yeah, no, it's probably not as much as I'd like it to be. One of the ways obstetrics has really changed over the years is Back it used to be you had your obstetrician followed you, you went into labor, your obstetrician came in and delivered you had a problem, you called your obstetrician. Well, now we share coverage. Tri-County, all of our obstetricians, as well as some other obstetricians in the community, we share coverage of labor and delivery at Milford. The benefit of that is that you have set time where labor and delivery is your domain. You're focused on that, so patients have improved safety. They have hopefully a well-rested physician as opposed to someone who could, like the old way, people could be up for days and days at a time.
Well, the old way in Milford, when the hospital was the Little Red Hospital, there were 4 doctors. And you could literally look and say, okay, it's either Cicchetti, Mastriani, you know, you go right down the list. There's only 4. So one of those 4 brought you into the world, and if you didn't behave, threatened to take you out. But today, now, how does that work, though? Because I saw the bond between my darling bride and her OB-GYN.
It sometimes, there's a trade-off, because I definitely miss that with some. Like, I'll come in the morning and be going through.
8 months you've built it up, and you hand the baton and somebody else gets to have the fun part?
Yeah, that's tough, but again, you're providing them with a safer experience. And I've had instances where I've been with a patient through labor, I've been there for 24 hours with them, and gotten them almost there, and someone else is coming.
24 hours of labor?
It can happen.
I would be dead.
When we show how strong women truly are.
Child number 1 was almost 3 hours. Quick. And my darling bride, my darling bride didn't see it that way. And she's reminded me several times. Luckily, child number 2, my oldest said she left breadcrumbs. So there was, indications. Child number 2 is a little over an hour, done, see ya.
Sorry.
24 hours.
Yeah. And there've been instances where at that 24-hour mark, another obstetrician has come in to relieve me, and having to turn that patient over is incredibly hard, but at the same time, knowing that I'm providing them the safest experience possible.
That makes sense.
One of my sayings that I always tell my patients is I have a birth plan for every patient, and my birth plan for every patient is I want a healthy mom, and I want a healthy baby, and I want to do everything we need to do to get there. And sometimes that's part of it, is letting somebody else take care of them.
Well, being up for 23 hours, I can see where you can't be at performance high at that point. It's got to take a little toll.
There comes a point where it's safer to get help.
But now, OB-GYN, tell me, on a normal week, if there is such a thing, how do you spend your time?
So most of my days I'm going to be in my office practice. I'm going to be seeing prenatal patients, so seeing them through their pregnancy, for their regular checkups for that. I'm going to be seeing women for their annual gynecologic exams, so doing well woman care. I'm going to be seeing patients for problem visits. People come to see me because of heavy periods or irregular periods or pelvic pain. They might get sent to me from a primary care because of abnormal pap testing that needs further workup.
There's an emotional roller coaster right there we've gone through, where you just can't help but think the worst.
Yep.
And then you get the highs when it comes back and says, never mind. It's like, thank you.
Yep. Yes, negative results are always a good thing.
Yeah, there's always a good, but now, so you go through the week. Give me an idea of the demographics. Mainly younger women, older women?
Given that we do a lot of obstetrics, that puts people into a certain age range. But then I also have a fair amount of middle-aged and older women. I see some adolescents. Some girls start coming to see me as early as around age 14. Definitely a lot of 15 and 16-year-olds.
Wow. It does seem that girls are maturing compared to when we were kids, much faster.
Yep.
You know, as a coach of 16 girls on a soccer team, the horrors of, okay, who said they could grow up? You know, we had them since they were 6 and 7. I was perfectly happy if they stayed at 7 and 8 years old and looked like 7 and 8 year olds for the rest of, you know, the time they played for me.
Yeah.
And then all of a sudden it's like, okay, they're 12 years old. They're not supposed to look this way. They look like, and you're proud because they look beautiful. They're young, but it's like, yeah, I'm so proud how beautiful they are. But on the same token, why can't they stay little cuddly kids?
Yep. Unfortunately, you got to grow up.
Why? But, you know, OB versus GYN, percentage-wise in your practice?
At this point, it's probably about 60-40.
Oh, well.
Yeah. It's a little bit more OB, but a lot of GYN.
Now, I mean, it's got to be a very personal choice. And even a primary care physician is a personal choice.
Yes.
But for somebody to come in, they move to the center of the universe, and it's not Uxbridge. So if there's any question, you know, somebody moves to Milford from out of town. How do you pick your OB-GYN?
Yeah, an OB-GYN, a lot of it, I think, is word of mouth. A lot of people ask their girlfriens.
Who do
they
you
ask their
the soccer
and their
field.
mothers.
That seems to be the great normalizing factor.
Yep, that's a common way. Also, a lot of it is primary cares recommend where their patients go. Like a lot of patients will ask their primary care doctor, I need a gynecologist, who should I see?
If you weren't an MD and you moved to Milford, how would you pick?
How would I pick?
What would you look for?
I probably would ask one of my friends. It's kind of the common,
Now your friend says, here's 3 that I know have good reputations.
Yep. One of the big things today is making sure that they take my insurance.
Oh, yes.
That's one of the things we tell everyone who calls is we need to make sure that we're in the right networks and whatnot.
Whatever, the Harvard, the Tufts, whatever.
Make sure they're taking new patients. With primary care doctors, that's a big ordeal for some people now, is finding a primary care that actually
is open to
taking new patients. Yeah.
My daughter, when she turned 26, she finally got thrown out of Holliston Pediatrics, and they said, "You're 26. You no longer can come here." She said, "But I've always come here."
Did they have to lock the doors?
Well, it was like, you know, you can see him like, okay, go away. We're locking the doors on you. They were so nice, but it's like pediatrics. Which part of that doesn't 26 fit into? And we had to literally call Uncle Phil and say, who? Because, you know, it's amazing how limited the choices are in your primary care. You know, I hate to say it, but it all seems they're all full.
It's tough right now. Definitely have to search. The hospital on their website actually has a little section for primary cares that are accepting new patients.
Really?
I frequently use it to tell because my patients will ask me.
Oh, they go the other way. Who do I go to for primary
Yeah, they do
care?
sometimes, and I frequently use that website to go and check. Who can I send them to?
Oh, that must be tough. I want to send them to Dr. He won't take anymore.
Yeah. One good thing is most that take children will take newborns. Because a lot of people who are asking me are asking for primaries for their babies, and so it's a little bit easier finding places for the babies.
So now you come in and you say, obviously we have to deal with finances. So I have Tufts, I have Harvard, I have Blue Cross. Do you accept those? That's one. But now, let's say I've got 3 physicians, and the technical aspects are all okay. You know, they accept my insurance. They're in the center of the universe, so I don't have to drive very far. You know, all of that comes together. Now, what's the tiebreakers?
Tiebreakers.
Is it chemistry? Is it?
Sometimes it's that. Like some people, a lot of people do want to meet you and see, can I have a conversation with this person? Do I feel like this person listens to me?
I wanted to meet my Dr. Sharp Chop. The kind of guy who's going to be poking at me for many years and stabbing me with sharp instruments. I want to know that I feel comfortable.
Some people, a lot of it's education. They want to look at your degrees.
Really?
See where you went to school.
I never thought of that. I mean,
I have heard patients that that's something they want to know.
somehow, if you're part of Tri-County, I got to believe you're certified.
Yes, and actually, I don't think I've noticed that as much since I've been here.
Because I'm just trying to think. It's not like they're going and hiring physicians with Kmart degrees.
No, no.
You know, if you think of anything besides the patient relationships and service, I mean, you always hear Phil, Ed, and Frank talk about the quality of care.
Yes.
So I can't imagine they're going to go hire a bargain basement.
No.
You know, I went to med school for a month.
No.
I don't think. So the degrees, people look. But, okay, I'm a chemist.
Okay.
What would I know about the quality of a medical degree from UMass versus from you somewhere else?
I don't know. So, like, some people, just a name can mean something, but some people like knowing that you're relatively local. They like seeing that you went to school in Massachusetts.
Oh, okay.
And that you didn't go to school in California. Not that that makes you better or worse, but I think that helps some people form a connection.
Well, you know, it's always been amazing to me, not only the quality of the physicians in the Milford Medical Center, but the longevity. You know, people don't leave, or they don't seem to leave. When one left, we were all like, what happened?
Yeah, I've noticed that here, that people tend to be here for the long haul.
Biggest challenge you faced during the week?
Biggest challenge I faced during the week? Probably prioritizing to get everything done. This one of the things I love about OBGYN, and also one of the challenges of OBGYN, is that I'm not in an office doing just office practice every day. I'm not just in labor delivery every day. I'm not just in the operating room every day. I'm having to combine those and keep all the ducks in a row and keep everything flowing.
Now here, I mean, this sounds terrible, and I'll apologize for how it sounds, but I've seen the effect of what I call prenatal care, because we'll get families that come from our old village in Portugal, and you see the first 2 or 3 kids, and they're about that high, and then all of a sudden, up comes one that 6-footer, same mother, same father. I got to believe it's the prenatal care that makes the difference in them. Not that one's better or worse, but how important is the level of prenatal care?
Prenatal care is really important. Even before pregnancy, preconception care can be really important. Optimizing someone's health before pregnancy can have an incredible impact on their pregnancy. A lot of times we don't see patients until they're pregnant. Actually, it's a great time for people to actually get into the healthcare system. People who haven't necessarily been going to a primary care, when they find out they're pregnant, most people do have a strong urge to take care of that pregnancy, and that brings them into the healthcare system. So one thing is optimizing their health in general. Prenatal diagnosis, it helps to, as early as possible, find out if there's any problems with that pregnancy so that we can optimize things.
What kind of problems?
Problems? Well, there's always the chance of fetal anomalies. We have a lot of options now for genetic testing, looking for different genetic problems. We have detailed ultrasonography. Most pregnancies get a detailed anatomy ultrasound around 19 weeks. And that can often identify problems with the pregnancy. Sometimes it's just small things that we need to watch more closely, watching baby's growth to be sure they're growing properly, watching the placenta to be sure it's nourishing the pregnancy properly. And then there can be serious things. There can be cardiac defects, and then some of the more serious things.
I mean, when you hear about pediatric surgeons or neonate, you know, your hats off, but I can't imagine.
Yeah, they're special people.
But now, when I hear genetic testing, does that help you actually take precautions, or is it just information? Because what can I do?
It's more just information. And a lot of that is optional testing. It's a completely personal choice whether to have a lot of this testing done. A lot of it depends on a person's personality. A lot of people want every bit of information possible, want to know absolutely everything, and whether it would change how they handle the pregnancy at all. It's not necessarily one way or the other, but they just want the information. Some people, they're pregnant, they just want to carry that baby, they want to keep it healthy, but again, a lot of the tests don't change what we can do during the pregnancy, so they say it wouldn't change.
Well, I mean, I can see tests, you know, and these aren't any fancy genetic tests, where you say, okay, I'm finding protein in the urine or something. Yep. Okay, your blood pressure's high. Okay, we can modify behavior to help it.
Yep.
You know, that nasty eclampsia word, and you know, and all of a sudden, and it's hard because if something's happening to me, I'm an old man. Well, you know, hey, I can go through anything. You know, but my darling bride, who's much stronger than me, I feel helpless. And now my daughter, you know, every bit of data I am scouring. You know, if I hear anything, first thing I do is walk into our chief medical officer. Okay, you've been doing heart-lung transplants. You've got to know something about this test. Tell me about it. I don't know that I could do anything with the results, but if there's information out there, I just want to know. What kind of tests? I mean, I remember when my youngest, we hit the amnio. And it was like a 50-50 shot of whether there'll be a defect versus a spontaneous, you know, miscarriage from the amnio.
Yep.
That was hard to make that call.
Yeah. The numbers are a little bit better now.
Good.
Yeah, but it's still a test that carries risk of pregnancy loss. That's why we take it pretty seriously. We want an indication to do a test like that. Some of the other tests we offer that are screening tests, so that don't necessarily give a yes or no answer for problems. Screening tests that look to see whether a patient has an increased risk of Down syndrome. If the test came back saying, yes, her risk is increased, showing she has a 1 in 50 chance that this baby could be affected by Down syndrome, then we offer them to go on and do a test like an amniocentesis to confirm, if the patient wants. And again, some patients may choose not to because it's not going to change.
You know, the one thing I never understood is when they say, do you want to know boy or girl? I can't, wait a minute. We want to be surprised. And it always killed me because you're going to be surprised one way or another. You know?
When they're going to be surprised. Yeah. There still are people who prefer to be surprised at the
Really?
time of birth. Yep. Which is hard because if you're the one doing any scanning or to
Yep, don't look there. Yeah, don't look there.
But some people, it is kind of fun to see the look on their face when they find out.
You know, the funniest thing was you sit there and I guess I can fess up and it's like, just please healthy. But when I heard a girl, it's like, I'm getting a girl, you know, and I was so excited. And then I had another girl. I had such a great time for 5 years with my first girl. I guess a boy would have been, you know, when I found out I'm having a grandson, I got excited about that. So I guess one way or another, it doesn't seem to really matter. You know, now we get to torture my son-in-law because my darling bride went to Penn State.
Okay.
I went to Holy Cross. He believes there's a contest between us to who can clothe the grandson in the most college. I'm winning. I found a little suit, 3 months old, with a little tie. It's purple, like Holy Cross. And of course, the poor guy, he looks and says, but neither your daughter nor I went to those schools. It's like, look, you've already done your job. You are now excess. This is our grandchild. And he will be purple or Penn State blue. We'll deal with that. So the surprise thing, But on serious notes, what are the most common tests people go for?
The most common tests, a lot of people right now choose to have what's called a sequential screen, where they have, it's a combination of an early ultrasound done around 12 weeks combined with blood work, and then a second round of blood work around 16 weeks. They combine the results from all of these to look at a patient's risk for having Down syndrome, trisomy, or spinal cord defects. And again, it's a screening test, so not a test that gives a yes or no answer, it just gives a risk assessment. And it's pretty common for patients to have that done at this point.
Insurance cover most of those?
Yes. And again, I mentioned that I won't say everyone, but most pregnancies will have the anatomy ultrasound done at 19 weeks. And again, that's, I think, part of the...
Anatomy ultra, yeah.
I think that's one of the biggest things people look forward to in the pregnancy. I mean, they'll come in 6 weeks pregnant.
Well,
when do I get my ultrasound? That's like one of the big milestones. All people we screen for gestational diabetes are around 26 to 28 weeks of pregnancy.
is that common?
It is fairly common.
Because I know when Alexis, my oldest, was born, it was terrible. There was a very nice young lady. I think she was all of, 90 pounds. And we'd go, and they have all the babies in the little room. And back in the Virginia, D.C. area was when they were stealing babies. Yeah, so me being old and conservative, I slept at the door. Nothing is going in and out unless I see. It's really, really simple. And the poor nursing staff would look and say, "You can't do this." I said, "Oh yeah, I can." The only time that baby is leaving my sight is when she's with my bride. But you'd be looking and be like, ooh, ooh, wow, 13-pound kid. It was like, she was diabetic, apparently due to the pregnancy. It looked like a linebacker. I mean, my daughters were 6, 8, 9, which again, my darling bride reminds me that they were rather large. But 13.
Yeah, that's a large baby.
Out of such a small person.
And that's one of the risks of gestational diabetes is macrosomia. It also carries risks of course, more birth trauma, increased risk of needing a C-section.
Yes, 13 pounds. I mean, that's a 6-month-old. My
That's
God.
a large baby, yeah.
When you look and you talk to people and they say, "What can I do?" Now, obviously, doing things like narcotics and smoking, I mean, okay, running through 495 during rush hour is probably something you eliminate. Drugs, over drinking, all of that noise. But on a serious note, if somebody says to you, "Brittany, what can I do to best help my baby?" What do you tell them?
Well, they want to be healthy. Before pregnancy, optimizing their health, regular exercise, trying to get aerobic exercise most days of the week, healthy eating, hydration, something that a lot of people find hard in pregnancy is keeping up with hydration and drinking enough water.
How much water should you be drinking? Or is it body related?
It can vary a little bit, but I encourage my patients to be drinking 10 to 12 8-ounce glasses of water a day during pregnancy.
That's a lot of water.
It's a lot of water.
But now, okay, so you got the mother being told she's got water gain, right? She's putting on weight. And I remember my darling bride was the most beautiful pregnant woman. Every time I looked at her, she just looked more and more, but you couldn't tell her that. To her, she looked like, I look like it's like, oh God, no, But how do you tell somebody who's gaining weight due to water gain or water retention that they need to drink that much water?
Well, another part of pregnancy is the kidneys are working overtime. You run into the bathroom every 5-10 minutes. Well,
I thought that was because my daughters were doing jumping jacks on her bladder.
No, that's because the kidneys are working harder than they do otherwise. And so you've got to keep up with that. If they're getting rid of that much fluid, you've got to put at least that much in. If they're not putting enough water back, they can headaches, they can just feel poorly, they can even get dizzy. So when a lot of people come
It
with,
sounds like normal dehydration side effects.
yeah, so when people start coming to me with some of these mild vague complaints, and I'm like, you got to drink more water. I myself was rather guilty during my own pregnancy of keeping up my hydration. I was a resident at the time, so I was very busy. I was working nights.
Oh, so you had all the time off to be able to relax, put your feet up?
No, I was working nights, and I was having trouble staying hydrated. And my obstetrician gave me an ultimatum. She said, you can keep working, but you got to wear a Camelback. One of those little backpacks
Yes.
with the straw. I had to drain it 2 times every night. And I had every nurse in the hospital running behind me, shaking the Camelback to see how much fluid was gone from it. And if it had too much water in it, they yelled at me to drink. So the entire hospital knew me as the doctor with the Camelback.
You with the Camelback, but with the healthy baby.
Hell yes.
Now, obviously, the weight gain, that always, and again, no, I hate to be sexist, but no guy can understand it. I mean, I just can't. There's my best friend, we've been married 100 years. Yes, she's putting on weight, and she still looks as gorgeous as ever in my eyes. I say something and you get, you know, the verbal backhand. What's normal for weight?
Well, a bit of it is going to vary depending on a woman's starting weight. If she's starting off underweight, we encourage her to gain a little more. If she's starting off pregnancy overweight, we
But you can't say X pounds, but is it a percentage?
No, like for an average pregnant patient, we do say about 25 to 30 pounds.
And the average patient weighs?
Well, we tend to go more by BMI, the body mass
Right.
index. What we consider healthy for a body mass index between 20 and 25. Those are the people we encourage to gain, usually we'd say 20 to 25 pounds. If they're starting off with a higher BMI, we might encourage them to gain more in the 15 to 20 pound range. If they're starting off with a BMI under 19, we might encourage them
to eat,
but also that it's okay to gain more in the 30-pound range.
Oh my God, I can't imagine somebody 19. It's got to be dramatic effects.
Yeah, and another way we phrase it is that usually if you gain up to the 25, 30-pound range, when you deliver, you're going to be able to get rid of that fairly quickly. Any more than that is going to be yours to work harder to get rid of.
So now, some of the questions always come up. Can pregnant women drink?
We do not encourage pregnant women to drink alcohol.
Any? Like no wine, no?
We don't have any U.S. studies showing any safe amount during pregnancy.
So better just to...
Yeah.
That's how my daughter got found. And it was terrible. We're sitting there at dinner table, and of course, this is my daughter. I'm not going to be... My mother and... sorry, my son-in-law's mother and my daughter, they're... I said, what's the matter? She goes, Lexi's not drinking. I said, so? Do you think she's pregnant? And they're going on, and I couldn't resist. I leaned over and said, Lexi, you pregnant? And they all went into this shock, like you can't ask. I said, it's my daughter, I can ask. But it was, she didn't have wine when we had dinner. That was the tip.
Yep.
Any other no-nos?
No-nos. We do tend to set lifting limits, especially in the 3rd trimester. We encourage people not to lift more than 10 pounds. People's balance can be different, so we encourage physical activity during pregnancy. We encourage people to continue to exercise, but you want to watch what kind of exercises you're doing, again, because your balance can be off. Anything that would predispose you to falling, and a lot of times lying flat on the back is going to be more uncomfortable. You can even get dizzy. So usually exercises that involve lying flat on the back.
Well, how do you sleep?
How do you sleep? We encourage people to sleep on their side, but not necessarily all the way over on their side, just tilted slightly, even a pillow under one side.
We used to prop my darling Bright up with pillows.
Yep. Yes. I encourage people to make a nest because it can be hard to get comfortable.
Well, you know, it's terrible because as the almost dad, you want to help, but you have no way of really understanding what's going on. You know, and okay, sometimes the hormonal balance may have been a question, you know, and you just have to kind of say, tell me what to do because I have no clue. So propping up was okay.
Yes.
What else is there a difference? What else can young potential mothers versus as they get older?
Well, as women age, once they get to 35, we give them the label of advanced maternal age.
Oh my God.
I know, I hate that we...
You're going to tell a 35-year-old that she's advanced age?
I know, I hate the label, but basically their genetic risk increases.
I understand, but just the idea of saying, excuse me, you're an advanced aged patient, I think I would want to do that by phone.
I usually just say that you're over 35. It puts them at risk, higher risk of having genetic anomalies. We often will offer them to have counseling with a genetic counselor. They get a more detailed ultrasound called a level 2 ultrasound that's performed with a perinatologist or a high-risk pregnancy specialist present.
What's really the difference when you say, I'm going to get an ultrasound versus a level 2 ultrasound?
It's the fact that the parent, one of the normal ultrasounds are looked at by the radiologists, who of course are incredibly well trained in reading ultrasound. The level 2, it's a perinatologist or a maternal fetal medicine
So it's
specialist.
really the physician's level of expertise that's reading it.
Yep.
Because the equipment's the same.
Yes, exactly.
It's not like, okay, you're getting the Kmart ultrasound. And somebody bring the one in from Neiman Marcus. We want, you know, the advanced one.
No, it's simply a matter of that those physicians have had specialized training in reading fetal ultrasound.
Now, we read more and more that the millennials are waiting to get married. So I'm assuming that's going to translate to waiting to have children. Do you see the trend? Is it getting older?
Like in my time, I haven't seen like the age range really changing that much, but I do have a fair number of over 35 patients.
Yeah, those age advanced, God
Advanced.
help you.
I know, I don't want to use that term now. But no, I definitely have a good proportion of patients in that age range.
How young do you typically see?
We still have teenage pregnancies. One of the things, I guess what I consider part of one of my jobs is proper education and counseling of patients on birth control and preventing the teen pregnancies. But we definitely have some that we see, and again, some high school patients.
How hard is it? I mean, when we had oncologists on, we had the discussion about, okay, HPV screening and do I really want to admit that my child is active? And you sit there and say, you know, we can pretend. You know, like I always told my darling bride that my daughter went to Holy Cross. They don't drink at Holy Cross. Sunday morning, the reason she's moving a little slow, she must have been in the library late at night. It's a beautiful fantasy that an old man can keep, but that's not life-threatening. How do you talk to the parents to say, right, wrong, or indifferent, you got to deal with today's reality? Is it hard?
I'd say a majority of patients are pretty open. One thing that's really we're lucky about with the HPV vaccine is that the age range they're recommending we give it to, we're actually giving it to young girls before, because actually that's part of the goal is to get them to be completely vaccinated before they're sexually active, to prevent them from ever having a chance to be exposed or to contract the HPV virus. And so actually I'm lucky in that respect that I'd say a good proportion of the time, by the time I'm seeing the patients, their pediatricians have administered the vaccine.
Oh, good.
And I think our pediatricians do a really good job of encouraging the parents
Well,
to give it.
I remember when my daughter was born, I said, I have no problem at all. She can start dating when she's 30. You know, it's very simple. You know, but then you have to deal with reality of, okay, if I do an ostrich, I'm putting my child's health at risk. You know, on the GYN side, do you see, are the girls coming alone? They come with their parent or their mother, or?
I'd say a lot of the girls under 18 do come with their mothers. Of course, I tend to see them, I'll see them by themselves and then ask them what they want me to talk to their mom about,
Yes.
and if they want their mom to come in for a discussion.
Well, I can imagine that you'll get a lot straighter talk, you know, at 16, 15. I mean, poor kids got to be confused anyway.
Yeah.
I mean, at least the internet you can read. Not quite sure that you get the good information. When you look at the young kids coming in, I mean, obviously getting vaccinated, I mean, it's a personal choice, there's no question, but I'd be more worried that if I didn't, it's not something you can go back on. What other issues do you have to deal with potential young mothers?
Potential young mothers. Well, still, I mean, sexually transmitted infections is a big issue with younger patients. And again, a lot of that is education and making them aware of the risks and how to protect themselves.
You know, it's amazing because when you think of what we had when we were kids, yes, it could be embarrassing and you could have to go and drop your pride and your pants and get a shot in the bum of penicillin. And then it went away. Today, it's still a big risk, even with all the information out there?
Yeah. I mean, we still have high rates of chlamydia and gonorrhea, which in women a lot of times can be asymptomatic infections. Then they can pose a risk of serious infections, but also infertility. Making patients aware of that. Like, again, sometimes they think that, oh, I get an infection, I get antibiotics.
Yeah, I get a shot of penicillin, amoxicillin, I'm done.
But when you tell them this could
well, you see
pose a risk to never being able to have a child, that's different than needing a shot.
Because, I mean, you hear the herpes, and, you know, you have to hope that people who are at a point in the cycle of being contagious would behave themselves. But how do you know?
One of the problems with HSV infections is that they can be actively spreading virus sometimes before they have lesions, so some people don't know that they're contagious at the time.
When you say asymptomatic, that's probably the scariest thought in my mind, that you could be involved in a long discussion and there's no malice on either side. They just don't know. Yet, surprise. Is it growing, shrinking? Are we getting better at educating our children?
I don't know that there's that much of a change in rate of some of these infections, but I think we're possibly better at having discussions. But I don't know. Again, with our schools having abstinence-only education doesn't necessarily help.
That's got to be tough. I mean, you know, you think back when we were children, we never did anything like this. We never drank. We never caused problems. You know, as an old man, selective memory is wonderful. But reality's reality. You know, I don't know how to get people to say, at least have the discussion yourself. You know, talk to your kids.
Yeah, education at home is one of the places they could get education earliest, and encouraging that.
Yeah, because, I mean, once it happens, a lot of these, you know, you start saying the HSV, if you're asymptomatic, oh my God. You know, and you can argue you shouldn't have. Yes, I agree. But you did. Now what? You know? So as you look in the future, and you start saying, this is what I want to do, does anything change? You do more OB, more GYN?
One of the trends that has sort of people have seen in OBGYN is people tend to, as time goes on, go more to GYN. Even a lot of people leave OB practice and go to doing just GYN.
Now, is that financial? Because I read, you know, you think about it, I know you're perfect. Every physician is perfect. They'll never make a mistake. But if a mistake happens, and you're treating, well, you wouldn't treat me, but, you know, a physician's treating an old man like me, there's a finite number of heartbeats left that they have to deal with. When you make a mistake or something happens, it may not be your mistake. It may be force majeure, but if you got to pay for it, you're paying for an entire life.
Yeah, I mean, the malpractice part of OB is what drives a lot of people out of it. But personally, obstetrics is still what I love, and I can't imagine as heart-wrenching as it can be and as much havoc as it can put on the rest of my life, but it's the part I really love.
But it's the passion of OB that keeps you there then.
Yeah.
It certainly isn't the money anymore.
No.
You know, I mean, when you join a practice, isn't most of it because of the admin and the insurance cost?
Yes.
Because I'm seeing more and more physicians, you don't see the single shingle anymore.
Yeah, a lot of things that contribute to that are the electronic medical record, which is going to be mandated
the infrastructure
by,
of EMR is just...
that is almost impossible to do. And then another thing is the push for the establishment of medical homes, where people are going to have networks of primary care and all the specialties that are part of a system. And it's going to be much harder to be
on
a
your
private
own
practice out by yourself.
Oh, I'm just thinking of the amount of paperwork and what you have to do just to be compliant.
Yes.
You know, and as you see the push on managed healthcare to, well, let me ask you, are you getting pushed to see more and more patients in less and less time?
I mean, ideally, and I think in our specialty, there hasn't been as much of a push of that, but there definitely is the potential.
But how can, I mean, okay, my primary care physician, and Dr. Chai somehow always has time when I have dumb questions. You know, I saw Fahim Farouk always had time for my mother. But, you know, it really wasn't, I'm going to monopolize 20 hours of his life. How do they figure out if you're efficient when you've got people like my darling bride with 45 minutes labor and the woman you mentioned with 24 hours labor? How can you...
Again, that's part of why we share coverage of of labor and delivery, because it makes it so we're in the office, we're able to concentrate on the office and give our full attention to those patients. Because yeah, in the days where you were leaving to go deliver babies,
yeah, I'll see you in 8 hours or 10 or...
I don't know how people could have schedules and have scheduled appointments, because that would be so difficult. So now, I mean, when we're in the office, we're in the office. And a lot of it is balancing. I mean, yeah, some patients are going to take longer, and so you tend to run late because there are some patients that need more time. But then you'll come to a spot where there's someone who doesn't need as much time, and you're able to fulfill their needs in a quicker amount of time and catch up.
Do you take care of entire families? I mean, when you say word of mouth.
I definitely have some patients where I have moms and daughters.
Is it helpful? You know the genetic makeup at that point.
It is. I think it helps to establish trust. Like a lot of women know that, okay, I've taken care of them, so they trust me with their daughter, and vice versa. It happens too. That, oh, my mom really likes you, so I wanted to come see you too.
Well, that makes sense. I mean, it's got to be hard. You know, somehow we all ended up at one primary care physician. You know, it seemed like my whole office did. You know, one of us went and said, hey, this guy's pretty good. You know, we never could say his name. He said, couldn't you change to like Smith? You had to try and learn to say Sop Chop Chai, and when you call in and try and explain who your primary care is, and they say, could you spell it? It's like, yeah, you want narcotics. I'm having a hard enough time saying it. But then next person, you know, your comment of word of mouth. just continuously streamed in. Now, as far as taking new patients, brand new facility, are you taking new patients?
I am taking new patients, yes.
How many patients can you treat, not treat, but handle, like as an average OB-GYN?
Well, one thing with OB-GYN is the patient load is always fluctuating because of the obstetric patients aren't staying pregnant
They aren't
forever.
coming back pregnant every month?
Yeah.
I mean, every year?
So there's a constant inflow and exit. So so it's not like a primary care who kind of has a set, these are the patients.
I've been going to the same guy for 20 years.
Yeah, because some people will continue to choose, or will choose to continue seeing me for a GYN, but again, that'd be like on a yearly basis, where some are comfortable having their primary care do their gynecologic care. So I might not see them for a few years until they have another pregnancy and come back to see me. But so the number of patients is fluctuating a bit more than other types of practices.
How often, you know, as a woman, girl becomes woman, becomes advanced age, God, I'm going to get comments. So I can see my email lighting up, you know, on that one. But every year, is it once a year they should come see you?
Guidelines are changing slightly. That is, I'm sure people are a little overwhelmed with what they see in the news about this guideline and that guideline. And it gets a little confusing now, because especially with the Pap testing guidelines have changed. Women kind of used to live by the fact that they needed their Pap test every year. A lot of people would call their annual exam their Pap test. And the fact that they don't necessarily need a Pap test every year anymore doesn't mean they don't need to see their physician. Most women should still be having a breast exam every year. Whether it's done by a gynecologist or by their primary care, it can be a decision amongst them. And they should be having a discussion with their physician about whether they should be having a pelvic exam every year. And again, that can be a personal thing based on their history and the current circumstances. Pap testing should be done routinely for women over 21, at least every 3 years.
So when I hit 21, 3 years, when does it change to annual?
It doesn't. But and again, that's the Pap test. That's not a doctor's visit. That's not a physical exam.
Is that right in that same logic where the sociology major said you don't have to have a breast exam every year? And then you look and say, really? Well, no, statistically, and you sit there and say, okay, I can deal with statistics with my car, with my house insurance, yes. But when you're talking about my darling bride or my sainted daughters, I don't want to hear about statistics. If it's safer once a year, why, if I can afford it, I mean.
There's been a lot of research into the timing of the Pap testing, and a lot of it's come out of the fact that most cervical disease is caused by the HPV virus, and realizing how slowly the virus affects the cervix, and that on the average, the change from mild changes to the cervix to cancer would take 10 years. And another part of the reason for extending it is another big part of medicine is do no harm. And there's concern that by screening too frequently, we could be identifying transient changes, mild changes that don't need extra testing, that don't need to be treated with surgical procedures, and that we're able to save unnecessary treatment by not testing as often.
But if you were testing every year and you get a transient change year one, you would think year two, you're back. Man, what is the do no harm? The only thing that scares me is every treatment I've ever been involved with, it's better if you deal with it early. You know, if there is an issue, better you should deal with it before. If I wait 3 years, seems like I'm giving any anomaly that isn't a long time to do bad things.
It's only if there's a completely normal test that we would wait for 3 years.
Okay.
There's different grades of testing, and if there's anything slightly off, then we test more often.
That makes more sense, because the idea of saying some sociology major read an actuarial table and said, 90% of the people won't be affected. Well, if my daughter's in that 10%.
No, if there's test results that show any abnormalities, then we're still testing more frequently.
Is the insurance an issue? Do people not get tested because of reimbursement?
With Pap testing, that has not been a problem yet.
Are there any procedures that you see that, people get nervous about on the GYN side, or even the OB? But I guess on the OB, you're really you've got a playbook you have to follow. It's not like, okay, we're going to delay this by a month till I can build up my credit to pay for it. Is there anything that gets in the way from a financial point of view?
On the GYN side, something I have noticed more and more is with a lot of people having high deductible plans, they put off a lot of elective surgeries. So not so much the routine care, because the preventative care with the Affordable Care Act should be covered. But people who want to have procedures to treat their heavy menstrual bleeding, or sometimes even patients who want to have a hysterectomy, sometimes they have a pretty high
a lot of them can have $2,000 or $4,000 deductible.
Or co-insurance, and they'll put it off. So some women will suffer through being miserable every month.
I was going to say, that's sad that, when we look at everything we have to do, making somebody suffer through because of, a deductible. Boy, I hope that's a very small number.
And some people, I have noticed more people trying to time things based on when their deductible is.
See, I can't imagine timing your activities. When I buy my glasses so that I hit next year's, I can live with these glasses for another 2 months, or that I can see.
No, I definitely have had patients say, I need this surgery within the next 4 weeks, or else I'm into my next physical
deductible?
year, and I'll have a higher deductible.
Well, as always, we thank you for everything you're doing. I can feel the passion. Brand new center in Northbridge.
Yep.
So hopefully it'll get all filled up for you. Not so filled up you can't take our kids and our darling brides. But thank you for everything.
Well, thank you.
And as always, to our 6 loyal viewers, and maybe a couple from Northbridge that want to hear, thank you for joining. May God bless, and may tomorrow be a better day at the Center of the Universe than today. Good night, all.
Not too long since I've been home.